Hi, I'm Dr. Stephen Mehta. I'm a board-certified cardiologist, and we're providing cardiac and vascular services to the community surrounding Decatur County Hospital. We've been doing that here now for 2 years, thereabouts. And during that time, we've managed to increase the types of services we're providing. Anything from as minimal as an EKG all the way up to stress testing and specialized CAT scans and even venous procedures where we could treat vein disease. And so we're looking to expand those services further as we go. So general cardiology, well, as everyone probably knows, cardiology is still the #1 leading cause of death in this country and worldwide. So unfortunately, some degree of heart disease is very, very common. But the scope or the scale of heart disease can vary tremendously, just from something as minor as elevated cholesterol or high blood pressure, all the way up to full-blown heart disease needing stents and bypass surgery, what have you. So anywhere in that spectrum is kind of what we are able to evaluate. Initial visit generally would consist of a detailed history and looking at things like obviously symptoms, but also background, other medical history, family history. Genetics is a big part of many things, including heart disease. And then following that, we'll see what testing might be appropriate. After that, oftentimes including non-invasive tests like an echocardiogram, possibly a stress test, possibly a Holter monitor, various other non-invasive tests initially. And then that'll give us a better sense of what kind of a heart condition we're dealing with and possible subsequent evaluation and treatment. So with a family history of heart disease, and as I mentioned, genetics is a big, big part of heart disease. We can't fix the genetics part of it yet. You can't change your parents. So what we'll say is let's work on the things we can control. And at the risk of oversimplifying, eat right and exercise. But obviously there's way more to it than that. #1 on that list is smoking or vaping or tobacco of any kind. That absolutely is a non-starter for anyone, but particularly with a family history of heart disease. Beyond that, as I say, staying fit, that doesn't necessarily mean needing to be a gym rat. Just stay active, keep moving, watch the weight, watch what you eat, and keep an eye on the blood pressure, keep an eye on your blood work, cholesterol, and other blood tests that can be used to evaluate how you're doing. Blood sugar, even though we're not talking directly about blood sugar and things like diabetes, there's still a strong correlation. So the better we can keep the blood sugar at bay or under control, the better that will ultimately be for heart disease as well.
Great.
Vein disease, unfortunately, is also very, very common. Close to half the population has some degree of vein disease. It's probably underappreciated and underevaluated because it's not typically dangerous. It's not a life-threatening condition, so for understandable reasons, I suppose, it doesn't get the attention that things like heart disease, heart attacks, strokes, etc., they do. Nonetheless, it's a very common problem, and it does really have an impact on quality of life, which is a big deal. That matters a lot. So generally speaking, veins, again, if you're sitting or standing, to get blood from your toes back up to your heart and lungs, blood's got to go against gravity to do that. The way it does that, there's a series of tiny valves inside the veins that keep the blood going in one direction. It's those valves that go bad for a variety of reasons. I mentioned genetics already, that's #1. Beyond that, in women, pregnancy is a big deal as far as affecting those function of those valves. Nature of work, prolonged sitting, prolonged standing, either extreme, can cause those valves to fail too. Once enough of those valves have failed, then there's no way to stop that blood from getting pulled back down into the leg. And at that point, then that vein is is non-functional or is abnormal. Again, not a dangerous condition, but as you can imagine, that blood, it just starts pooling in the legs, and that can cause the typical symptoms of swelling and heaviness and leg cramps and discoloration, varicose veins, obviously spider veins, all those types of things are signs of the blood that's pooling in the legs, and that works its way out to the skin, and that's causing all the things that we could see and ultimately the things that we feel. Again, not a dangerous problem, but certainly a significant one, and unfortunately a treatable one. So I mentioned when the valves, enough of these valves fail. Again, these are tiny little valves inside the veins that keep the blood going in one direction. I describe it as sort of a fish ladder, or some way that we get the blood back up to the heart. When those valves fail, enough of them, then the vein itself just becomes a big hollow pipe, and every time you sit or stand up, gravity just pulls blood right down into the pipe, and there's nothing, no baffles, nothing to catch it. When a vein gets to that point, there's no way to fix it. So in the old days, we used to take them out. We do what were called vein strippings, and people are probably familiar with that term. And it's literally that. We would just take out the bad vein. And it works as a procedure, but it's kind of invasive, involves a hospital and surgery and downtime, etc. So we don't do it that way anymore, but the concept was still accurate. We don't want blood accumulating in these bad veins. So instead of taking the veins out, what we do now is we leave the vein where it is in the leg, but we close it down. And there's different ways and techniques that we have to do that. Generally speaking, there's what are called thermal techniques, meaning hot. That's laser radio frequency. Those both work the same way by increasing the temperature and basically cauterizing the vein closed. Obviously, everything is all numbed up. It shouldn't be a particularly painful procedure. There's different techniques as well. There's a surgical adhesive, literally a glue, that will sometimes glue the vein shut. And then there's a type of foam. More recently in the last 5 to 10 years. And that is a matter just of starting an IV, literally just putting a catheter in the vein. We inject the foam into the vein. The foam doesn't stay in the vein. It's not like caulking or something to plug the vein. The foam activates or irritates the lining of the vein, and then the foam's washed out of the body and is gone. While that lining is activated, then we use external compression, just a compression sock or some dressing, to keep pressure on that vein to keep it closed, and the vein in essence will seal against itself, and that's what keeps it closed down and prevents blood from re-entering it. For now, anybody that's got a device, be it a pacemaker, a defibrillator, even loop recorders, various other devices, monitoring style devices, we now have the ability and the capability of checking those devices to make sure they're functioning okay. So there's different ways that we can monitor these devices. Most people who get pacemakers or defibrillators will be given a machine or a unit that they take home and they leave on their nightstand that will monitor the device, and then by telemetry send the data back, typically to the doctor who inserted the device in the first place. And that's a great sort of a day-to-day tracking mechanism. What we're talking about doing is sort of a deeper dive, if you will, onto the functioning of the device itself. We can not only look at additional parameters beyond what the bedside box can do, but more importantly, we can make changes should we need to. And I won't get into all the parameters that can be changed, but we can change those if need be. So pacemaker, most devices, pacemakers, defibrillators, if they're stable, if they've been in for a few years, we're talking probably once or twice a year would be adequate checks. If it's been sooner or later, if it's at the end of life, then we want to check them more frequently to make sure that we're not running out of battery. If it's early, if it was just implanted, we want to check it fairly frequently as well to make sure everything's working properly. Once we hit sort of that sweet spot, then say 2 years to 8 years, then generally once or twice a year is likely going to be adequate. So when it comes to evaluating for underlying heart disease, there's a couple ways we could do that. Obviously, the history I mentioned before, but more importantly, we want to check for the blood supply to the heart. When we talk about blockages in the heart, things that ultimately may require stents or bypass surgery or things of that sort, Well, we're talking about our blockages inside the arteries that are preventing blood from getting to the heart. There's different ways to evaluate that, but from what we call a functional standpoint, meaning is the heart getting enough blood, stress testing is the simplest way in which to do that. And we call it stress testing, but stress testing is a very broad category of tests. It can range anywhere from just starting an IV and putting some medicine through that all the way to the full-blown treadmill is much as you can do, and anywhere in between. And so depending on the physical capabilities and some other medical conditions perhaps that the patient has will determine which type of testing we want to do. So, but generally speaking, the end result is the same. We're looking to assess the blood flow inside the heart and to see if the whole heart's getting blood adequately. So another cardiac test that we frequently do is called an echocardiogram. That's basically a type of ultrasound. Ultrasound generically is a test that uses sound waves to image whatever it is we happen to be looking at. You could do an ultrasound literally almost on any part of the body. In our particular context, we're looking at ultrasounds of the heart. So that specific test is called an echocardiogram. It oftentimes gets confused with an electrocardiogram. And an electrocardiogram, or what we use EKG or ECG, that's just where we wire you up and we get that little squiggly line piece of paper that shows us the EKG. So this is different from that. So that's an important distinction because that gets confused all the time. So an echocardiogram is an ultrasound test. So what that does is that looks at the main pumping chamber of the heart, shows us the strength of the heart muscle. It looks at the valves inside the heart, make sure they're functioning. It can measure pressures and blood flow. Lots of information we can get from an echocardiogram, all non-invasively. So it's a great test to look at kind of the overall function and how the heart's working. I would say that between a stress test and an echocardiogram, if both of those two come back okay, that covers about 90% of the bad stuff as far as the heart's concerned.